Hi everybody, I'm Jill Fenske. I'm a family physician and a medical director at one of our residency sites here at the University of Michigan. And I'm pleased to be here today to talk to you about ambulatory pain guideline that I was part of a team to develop here at University of Michigan.
And I'm Tom Bishop. I'm one of the assistant residency directors at our clinic and really responsible for developing our integrated care model that serves as a complement and a part of bringing about this pain treatment guideline. And so with that, we'd like to say that there's no disclosures other than we are doing our best in presenting this in this format. And in terms of goals and objectives, you can see them there. For the most part, we're trying to not only identify a biopsychosocial model for assessing and intervening with chronic pain. We're going to describe some central tenets of a pain management guideline and then explain how an integrated care model can assist in bringing about safety and good clinical intervention.
Next. So I thought it would be good to frame our discussion today in terms of a case presentation. And I took some elements of several cases that I have been involved with taking care of patients with our residents over the past several years. I think this might be familiar to many of you as well. So I'll just read through this case. It's a 60-year-old man who presents as a new patient to our resident clinic, and he was in a motor vehicle accident 30 years ago, suffered vertebral fractures at that time, and then subsequently developed chronic pain. And he's been taking OxyContin 60 milligrams twice daily with oxycodone short-acting 10 milligrams 1 to 2 times a day for breakthrough pain for many years now. And he presents to get established for care and requests a prescription refill. Next. So I'm sure we're all familiar with the challenge of chronic pain management in a busy ambulatory clinic. The time limits that many of us face in our time in clinic make it difficult. There definitely is a lack of physician support and in some cases education on addressing chronic pain in a safe and effective manner. A common thing that comes up at my clinic is the issue of inheriting difficult opioid management situations, whether it's a new patient getting established at our practice or a resident or faculty, physician, patient handoffs when a resident graduates or moves, and the new physician kind of inherits the current situation with medication management that they may or may not agree with or be comfortable with. And then we're also all aware of the poor access, unfortunately, to non-opioid pain management services, things like physical therapy, non-pharmacologic treatments that can be expensive and often aren't covered by insurance or might just be hard to access in certain areas. Next. And on top of those challenges, we're all faced with the opioid epidemic. Over the past 10 years, there's been skyrocketing incidence of overdoses of opioids, both prescription and non-prescription opioids. This is a slide from the CDC, which I'm sure you've seen or are familiar with similar slides showing the uptick in number of overdoses. Next. And with our current situation with COVID-19, unfortunately, early data shows that we're having even bigger problems with the opioid epidemic. And over 40 states right now are reporting increased rates of opioid overdoses. And as you are aware, there is kind of a twin pandemic of mental health and substance abuse worsening with the pandemic and the isolation that goes along with that. Next. Another layer of complexity is that attempts over the past 10 years to try to limit prescriptions of opioids have had some unanticipated outcomes. In 2016, the CDC put out some new opioid prescription guidelines, which did recommend many beneficial practices in terms of opiate prescribing, but the application of those guidelines sometimes was difficult, and given limitation in resources and training and stress that many physicians experience in patient encounters with opioids, sometimes these rules were applied in an inflexible way, and patients were essentially cut off, even to the extent of some practices deciding they weren't going to prescribe opioids anymore. And so it did lead to some patient abandonment and sudden discontinuation of opioids for patients who had developed dependence, and some poor outcomes. Next. So in the setting of all of these challenges, the team that I was part of at University of Michigan started work almost 2 years ago now on trying to come up with a new ambulatory pain guideline for our institution, utilizing the best evidence and looking at ways that we can support patients with this difficult issue, as well as hopefully keep them safe and avoid some of the bad effects of chronic opioid prescribing, and support clinicians in trying to do this difficult work. So one of the first pieces of that the guideline team looked at was assessment of chronic pain, and how could we look at chronic pain in a new way? What's the current evidence suggesting is the best way for us to approach chronic pain in terms of assessment in clinic? So, getting back to the case that I brought up earlier, I'll just kind of phrase a question to you to ponder about what else you might want to know about this situation. And if you were the preceptor or the resident seeing the patient, or the behaviorist getting involved with this case, what would you want to know about his history and his symptoms? Next.
And so to really do a good job in terms of assessment and take a different perspective, we wanted to remind you about having this particular perspective. And so that would include things like understanding that chronic pain is best understood as a disease process rather than a symptom. And so to begin with that makes sense, right? So in understanding that there's a significant cognitive, affective, and interpersonal components, all of these play a role in understanding pain. And that this type of pain that we're talking about, or the pain that we're talking about, is unlikely to resolve. And so focusing on maximizing function and limiting disability is probably the direction to go. Next. So when we talk about a biopsychosocial model of assessment, I'm going to work on unpacking a few things. And so in the next few slides, we're going to talk about things like noting the evidence for best pain management. We're going to do that in a second. Utilizing an integrated behavioral health team. And that's one of the things we find, and you'll see that from the evidence in a minute, that it makes sense to have a team approach. And that we're going to look at some potential relevant psychosocial domains that are good to look at when you're doing this assessment, and then maybe some screening tools. And these are not meant to be comprehensive, but just some ideas. Next. And so while this is a busy slide, I actually had seen this when Julie Rickert was presenting, Dr. Rickert. And in this, you'll see that when you look at the grade A evidence, there's a great deal of importance about the relationship, that there's a good partnership. And so establishing that partnership seems to be an important element in good treatment. And that there's a psychosocial management. So looking at things like cognitive behavioral interventions and self-management, some sort of behavioral aspect other than or along with the medical side of these things, right? I should say it's a overall health approach, right? And so just some of these things that give evidence and support for having a biopsychosocial perspective. Next. So when you look at these domains, some of these are intuitive. Maybe some of these you haven't thought of, right? So looking at relaxation, exercise, things like sleep, relationships, taking a look at each of these domains is important, especially if we're helping our patients to develop a lifestyle in the way that they approach their pain. Next. And so the interdisciplinary involvement of pain assessment might include things like utilizing an integrated team. We're continuing to talk about that. And then maybe approaching the interviewing or the the elements of a person's functioning through this acronym called SCREAM. And so I've been presenting this to residents, particularly when I was working in inpatient, but it works in the clinical setting as well. And unpacking that, what we're talking about is looking at the psychosocial aspects of a patient's background, culturally where they're from, and how that has helped shape them. Things like what sort of spiritual sort of connections, that's the R, religious sorts of things. And then economics certainly play a part in the way that they're going to address pain and the way they're going to address treatment. And then their level of education, and then certainly medical, meaning all sort of physical aspects. And so you can see this is one way of approaching a patient so that you gather all of those psychosocial aspects. Then there are certainly tools like the PADIT, the PADT. I don't know if I ever say that quite right. The PADIT doesn't quite sound right, but the 4 A's, using chart notes, and then understanding extreme and moderate risk factors. So extreme might be things when a patient's really in crisis. They might be suicidal. There might be other things that say that they're in a crisis in the way that they're functioning or not functioning. And when we talk about moderate, it's a history of things like depression and anxiety in the backdrop, and even some like family potential, or that they might be more susceptible to addictive kinds of styles. And so those moderate risk factors, paying attention to both of those is important for assessment. Next. And so in history taking, we're moving a little bit deeper here, but you can see like their pain history. And I would probably talk about not only the chronic or the more severe acute moments, but the chronic moments. So gathering both of those things in that history. Medical and psychiatric comorbidities, just kind of talked about that a little bit. Social history, substance use, suicide risk assessment is really important. And then a history of trauma, that often gets missed, particularly in primary care settings. And we could talk more about that. And then level of function, which is really important. Sometimes we at the risk of getting so focused on some things, we miss what they're doing in their daily lives or not doing, or what they prefer and wish that they were doing. Next.
So I included some slides here, which you can download if you want to get our slides and take a closer look. Just an overview of a tool that we developed at University of Michigan to actually integrate into the electronic health record. And we're calling it the pain profile, but this can be released to our patients that are on our health portal or given a copy on paper or if they're in the office. And it's really a way for the patient to tell their story and to have that actually be a part of their record that can be referred to then by specialists, by the whole team. So as part of this pain profile, we asked them to give us a narrative about their experience of pain. You can click through to the next. And then there's a body map, and you can click through again. And a host of questions about some of these items we just talked about, looking at a complete comprehensive history of their pain. So this is a tool that can be useful for patients to complete even before their appointment and bring some of that information in for the team to review. Next. So back to our case here, I wanted to fill in a few more details after our resident goes back in, maybe after some prompting from Dr. Bishop perhaps, and gets a few answers to some more of these questions. So turns out that our patient has a history of lumbar pain with radiculopathy, experiences some burning in the posterior thigh, has done physical therapy last 5 years ago, but it didn't really seem to help, and also injections haven't helped. So there's a little more of a comprehensive pain history. And then in terms of medical and psychiatric comorbidities, patient does have obesity, sleep apnea, using CPAP, a history of depression. Current PHQ-9 is 6, so sort of mild to moderate range there. Social history, smoking cigarettes, pack per day, no other substance use, no suicidal ideation or past suicide attempts. And in this particular case, we did a ACE survey, and he scored 4 on that for trauma history. And then level of function. Patient is currently on disability for the past 15 years. Next. After doing all that good assessment, which can be a lengthy process when you're getting to know a patient and they're meeting with all the team members, I'm going to take you through the next few steps in our guideline. And what we thought was an important next step was identifying neurobiological pain type. Kind of beyond the scope of this talk, but there is a whole new classification of chronic pain that was just published and will affect everything from diagnostic codes to maybe how we label and think about pain. Without getting too much into the weeds about that, I think a more basic understanding just of what the neurobiological pain type is a good place to start and a good place to help our learners try to start, because that really can help direct you to different treatment options. So the main three categories that we talked about in our guideline were nociceptive pain, so sort of the traditional bruise, fracture, injury type pain that we think about as being acute and then improving, or chronic arthritis pain would maybe be an example of a chronic type of nociceptive pain. Neuropathic being the classic nerve pain, and there's many different neuropathic pain syndromes, and then central sensitization, which is more of a central nervous system process that can play a role in many types of chronic pain. Next. So after thinking about a comprehensive assessment and what type, or maybe more than one type of neurobiologic pain the patient's experiencing in our guideline, we encourage people to then go into constructing an individualized treatment plan for patients. And the key things to make sure that this treatment plan takes into account are doing shared decision making and making sure the patient has some agency in making that plan and has options they can consider, emphasizing the lowest risk interventions and non-pharmacological interventions. Every pain plan should have non-pharmacologic treatment interventions as part of that, and really emphasizing that we want to start with low risk interventions rather than going right to pharmacologic or especially to opioids. And that gets me to the last point, which is that opioids are not indicated for most patients with chronic pain. I think many of the pain algorithms of the past often would have, try this and this and this and this, and then at the bottom, if nothing else works, go to opioids. But in our guideline, we're recommending kind of shifting away from that idea that not all paths end up at opioids if other things aren't working. Because there are certain types of pain for which opioids are just not indicated, that don't necessarily even help and can actually worsen function and increase risks. So I'll share some algorithms in a bit from our new guideline, but we're really advocating that opioids not necessarily be part of the treatment plan, even if other measures have been exhausted. So next. So I know you won't be able to read these right at the moment, but I've included a series of tables here from our guideline for you to reference if you decide to download our slides. And this is getting into a little more detail about the individualized pain treatment planning. And I'll just cover there's really 5 main steps with those overarching principles I just shared about shared decision making, lowest risk interventions, avoiding opioids in most patients. The first part of the treatment plan is actually the assessment, which we just covered and talked about how comprehensive that should be, and then trying to determine what the neurobiologic pain type or more than one type might be. And then emphasizing as a second step, establishing that therapeutic alliance with the physician and the whole team. And setting some goals, shared goals for improved function. And really emphasizing that a goal is to improve function. Goal is not to be pain-free, but to manage the pain in a way that allows there to be still a good quality of life. Setting some goals, providing some pain psychoeducation and self-management techniques. That's where I think it's really important to have the interdisciplinary team to help with a lot of that. Then getting to step 3, which is non-pharmacologic interventions. And that we broke into 2 different tiers. The first tier we'd recommend for all patients dealing with chronic pain, and that incorporates a lot of lifestyle changes. So things like sleep, diet, weight loss, exercise, physical activity. A lot of patients with chronic pain are fearful of activity, but emphasizing, finding an activity they can do and talking about how important it is for chronic pain to remain active. And then the second tier under these non-pharmacologic interventions is a whole slew of other targeted therapies, which can incorporate anything from physical therapy, alternative medicine therapies, acupuncture, and then psychological therapies as well. And then as a step 4 in this individualized plan, we do go to pharmacologic therapy, first starting with non-opioid pharmacologics, and then also other procedural interventions that might be a consideration for the patient, having them see a specialist in anesthesia or physical medicine rehab, thinking about things like injections or even surgical procedures if that's appropriate. And then 5 is sort of the monitoring phase, where we're continuing that relationship, having frequent follow-up, checking in, trying to address barriers that the patient may be running into with carrying out the treatment plan, things that didn't work, making adjustments, and then sort of just continuing this a circle, going through these 5 steps. Next. So these next several slides I'm not going to talk about in detail, but they're here for your reference. These are tables from our guideline, going through evidence and recommendations for non-pharmacologic treatments of chronic pain. Next. Herbal supplements, a lot of patients ask about, and this can include some information about cannabis products, because that, as I'm sure you're finding as well in our clinic, a lot of patients are using various products. Many states now have legal medical and recreational marijuana, and people are using it and asking about it all the time. I will call out just our little take on that here, since I know it's a very an area of a lot of interest for people right now. What do we advise patients? And after reviewing all the evidence, we found that the quality of evidence is very low, first of all, because of marijuana being Schedule I controlled substance in the United States. There really hasn't been good research because of the status of the drug. And so there is some evidence that it might play an anti-inflammatory role. There's probably the best evidence for neuropathic pain. Some studies have shown potentially benefit there, but a pretty mild benefit. What we decided in our guideline to advise people is certainly talking about the risks of THC and encouraging patients who are interested in trying cannabis products to avoid the THC. The unfortunate part is that the products are not well regulated, so it is difficult to try to have patients make sure they're finding a pure product that would just be CBD, and certainly we don't recommend prescribing that or pointing people to that because it's not well regulated. So discussing the risks is important, but also supporting patients who may wish to try CBD oil, that being supportive, but also talking about things to watch for and concerns about products that might be contaminated with THC. And as a point, another point that comes up a lot is, what do we do with patients who are on opioids and using cannabis products? And our take on that in our guideline was, CBD products, if that's what the patient is using, are thought to be pretty low risk for patients using opioids, but we certainly don't recommend concomitant use of THC-containing products and opioids. So just took a little detour to talk about that, since I know it's an area of interest, and how we handle that in our guideline. Next. So we also have a chart in our guideline going through some of the evidence and things to know about all the non-opioid pharmacologics for pain. So you can review that if you're interested. Next. Really, I think where a lot of our focus and time in the guideline was spent was on opioids. And so I shared 2 algorithms here that we came up with for our guideline on how to handle opioid prescribing in the setting of chronic pain. This first figure goes through how to make a decision about whether to even consider it as an option for an opioid-naive patient on chronic pain. Again, I won't go through this in an exhaustive fashion, but you can refer to this on the slides. Basically, we recommended first going back to that individualized pain treatment algorithm, making sure there's a really thorough assessment that we're addressing all the comorbidities that might be present, that we're trying all the other safer and first tier options for pain control. And only if all of those things are not resulting in improvement and function, then asking the question, are opioids reasonable to try? And by reasonable, we mean, is there potential of benefit with low risk? So, someone who doesn't have some of the comorbidities we might worry about, like sleep apnea, chronic pulmonary disease, suicidality, other substance use disorders. If there's someone who doesn't have a lot of these other risk factors, if we can start with a safe dose, trying to keep it under 50 morphine equivalents a day. If we're going to have close monitoring and follow-up and continue some of the alternative other treatments as well, that's really the things that should be considered, as well as discussed with the patient, including all the risks inherent with using opioids and what markers you're going to use to determine if it's helping or not. So we really are advocating a thoughtful approach to even considering opioids, and not necessarily having that be the natural end point of the algorithm for all patients. I'm really trying to make an individualized decision. Next. Another situation that we come across a lot in clinic, like the case I shared, inheriting patients who are already on opioids, or patients who maybe we ourselves have started on opioids a long time ago, and now we're seeing that the risk is high, or there's new health factors that come into play that make the risk higher for that patient. So what do you do with all of those patients? And this algorithm, as you can see, is very busy, but it tries to address that in a similar fashion, trying to take a step back and say, are opioids reasonable for this patient? As you can see with all the footnotes that are here, it kind of gives you some of those questions to think through in each case. Looking at dosing, is that safe? Looking at comorbidities, is that safe? Is the patient deriving benefit? A lot of patients are on very high dose opioids and still not deriving benefit. And there are conditions like opioid hyperalgesia where the pain actually gets worse with opioids, or a condition called complex persistent dependence, which can also be a play. So we hope that this algorithm provides some guidance for our clinicians who find themselves in those difficult dilemmas with patients, and patients as well who are through no fault of their own maybe escalated on inappropriate opioid dosing, and now are having issues related to that. So next. So this kind of gives you an idea of a potential treatment plan for the patient in our case, using the processes that are outlined in our guideline. So our initial assessment for this patient was that there's probably a combination of nociceptive and neuropathic pain. There may even be some centralized components here, or opioid hyperalgesia or complex persistent dependence, which I'll talk a little bit more about in a bit. And there's certainly multiple medical and social comorbidities for this patient. I think, as Tom will talk about a little bit more in a bit, the therapeutic alliance is so important. We're just meeting this patient for the first time. It's really important to really get to know him, hear his story, try to develop some rapport with the patient and with the team, and also get a sense that he will not be abandoned. I think many patients are fearful, and they come to a new doctor, they're on very high opioid dosing. What's going to happen? You're going to cut me off. I think there's a lot of fear that can go into some of those first encounters, both on the patient side as well as the clinician side. So trying to develop a relationship and a commitment to the patient to help figure out a plan. Non-pharmacologic interventions, Tier 1, working on all the lifestyle measures, which I think your team can help with, and having good care coordination for this patient to support them with making some of those lifestyle changes is important. And then Tier 2, looking at some non-pharmacologic interventions that the patient may not have tried before. He's had physical therapy without good response, maybe asking a little bit more about that, where he went, why didn't he think that the therapy helped, what kind of experience did he have. There's a lot of different approaches to therapy that might be something he could try. Thinking about some of the other psychological therapies that might be worth exploring. So really spending time on that non-pharmacologic interventions. And then other interventions to consider, pharmacologic, non-opioid. We certainly want to run through the table of all the options there. And he has some comorbidities where, an SNRI or another option there might be really helpful. And procedural interventions. It may be worth having him get established with PM&R again and see if there are other options that we could offer him. And then getting to the opioids, which is certainly, I think, the most stress-inducing part of this case. I think that in a compassionate way, talking to the patient about trying an opioid taper or even conversion to buprenorphine would be something that he may benefit with over time. And that doesn't have to happen overnight. But I think that's part of why it's so important to build a good therapeutic alliance with the patient to help with that. And then, of course, monitoring and seeing the patient frequently. Next. Before I turn it back over to Tom, I just had a couple other slides about complex opioid cases and this notion of complex persistent dependence. So these are just some safety and monitoring suggestions for patients on opioids. Of course, you want to do all of those good safety measures, checking the prescription drug monitoring program, reports from your state about where the patient is filling opioid scripts. You want to get a urine drug screen. You want to have controlled substance agreements. Mm-hmm. These have become really standard practice in I think most clinics. You want to have that informed consent discussion with the patient. And here in the state of Michigan now, we actually have the legal requirement to do a written, signed informed consent document for opioids. You want to continually ask at every visit, are opioids reasonable and safe for this patient? And then if you are going to taper, seek out some resources and some help if you're not familiar with that. But my advice would just be to go slow, add in alternative treatments, and then I'll have you advance the slide to the next one. Considering this complex persistent dependence. At the bottom of the slide, I have a link to an article there by Ballantyne's group, which I found to be one of the most helpful articles I've read in the last several years about chronic pain and opioid management, because it really, through a series of cases, it talks about this notion of complex persistent dependence, which was new to me a couple years ago, and I think is new to our learners in most cases, but this is sort of a syndrome that can happen for patients who've been maintained for many years on high opioid doses. I guess the way I describe it to patients is your brain has changed because you're on all these opioids, and it leads to these types of behaviors that sometimes people feel are indicating addiction, aberrant use, anxiety about the medications, the frequent calls to clinic about medicines running out, those type of behaviors, and really can lead to impaired function and sometimes worsened pain as well. And so the key thing to think about is certainly not to escalate opioids further, and the one intervention which does seem to really help these patients is doing a transition to buprenorphine. And in our primary care practices, more and more physicians, I think, are getting wavered, getting some comfort with use of buprenorphine for medication-assisted therapy for opioid use disorder, but you don't need the waiver even to prescribe buprenorphine for pain. And
That's right.
I think it's a very useful tool, which I've started using more just in the last couple year or two. I'm new to this as well, but I've had really some dramatically, really amazing results of getting patients off really high dose opioids onto buprenorphine. And I had a phone visit because of COVID recently with one patient that I just had some experience doing this with, and she's like, I haven't felt this good in years. You know, she really had a great outcome. So I think we need to learn more and more about use of buprenorphine and gain comfort in that, and help our learners as well, because I think it does have a role for some patients in these situations. Next.
So I'm going to talk just a little more about that notion of having a team approach. So there were several things that were discussed along the way, like how we go about establishing a really good working relationship. And a team can do that, right? Especially if it's an integrated where they break down those silos and we're actually communicating and see it as a one individualized plan that's developed with them. So we're not separate plans. And so we talked about that and meeting the patient where they're at and helping to work on lifestyle changes. And that's where a good integrated approach can work. Utilizing things like motivational interviewing, of course, setting up pain agendas, setting tools, chronic pain, personal care plans. In a minute, and I'm going to show another slide here where Dr. Julie Rickard, again, she had presented a number of things you'll see on this slide when she was back in her previous site, where these are great sort of patient-driven handouts, things on like sleep and exercise and, you know, all those other, remember those things that we discussed earlier that all contribute to a good lifestyle and an ability to manage pain differently. And so with that, next slide. We would ask you if you have any questions, but since it's just us here and Joe, there's not much.
We'll ask our cameraman, Joe.
Yeah, that's right.
If you have any questions. So hopefully we will connect with you at our live session if you have questions. Certainly feel free to contact us if you are watching this asynchronously and you want to chat about anything we brought up. You can forward to the next one, Joe. I just wanted to include some acknowledgments for the pain management guideline team that I was part of here at University of Michigan. This was a multidisciplinary group of people from various disciplines. So we had internists, we had physical medicine docs, we had anesthesia docs, we had education sort of specialists that helped us with developing that guideline. So
very good.
Then we have next some references. I think that's it.
Yeah. Well, thank you.
Thanks.
We look forward to
everybody.
talking to you.